he's going to go into the GDV. Dr. Garifage is a surgeon that I worked with. He's amazing and I love him. I'm going to let him give you a brief history of himself, but you guys will be super impressed with everything that they have to say. So I'm going to let him take it away. Also, we're going to hold questions to the end. So use the Q&A and I will drop questions at the end of this for you. All right, Shadi, it's all you.
Thank you, Ashley, and thank you, AmeriVet, for letting me do this. This is very exciting. Hopefully you folks find it clinically relevant. And as you said, the proceedings are way more detailed than this talk will be. So this talk is intended to be very practical, very clinical. They just sort of enjoy the ride. Any questions, please let me know. The proceedings have an insane amount of detail. It has got beyond the last 5 years worth of medical literature in it. So feel free to use that as you will. It's quite detailed. So we're going to be talking about GDV. As Ashley said here's my background. I graduated from Cornell University in 2006, did my internship at Angel, then became board certified in small animal surgery. After that, did a few other things in other hospitals, and then ended with Vet Triage. I'm currently the CMO of Vet Triage, and we'll go over that platform in a bit. We've got a long list here of things to go over. Obviously, GDV is a multifactorial, complex disease process. And as Ashley said, we're going to also talk a bit about Vet Triage as well and how it can help folks, especially those who are a bit on the newer side when it comes to veterinary medicine. So the prevalence of GDV, we all are aware of how common it is. For every 1,000 dogs admitted to a hospital, somewhere between 2.4 to 7.6 dogs are affected by GDV. And within a lifetime, 15% of dogs will die of GDV. It's very, very common. There's a lifetime risk, broad range, and that's because the risk factor depends on a multitude of things, but this specific range has to do with breed. So the deep-chested dog breeds, large and extra large, giant breed dogs, they're the ones that make up the risk. It's typically a disease of middle age to older. If you look at the mean of 6 to 7 years of age for affected dogs, when you take into account breeds like German Shepherds and Great Danes, 6 to 7 is geriatric or elderly, older, right? It's not really middle age so much. So it's a bit skewed in terms of that age range, but it can be any age affected, young or old. Of course, they are medium, large breed, giant breed dogs. So 85 pounds is the average reported, but any dog breed can be affected by it. I've had smaller dog breeds as well be affected by it. And as far as deep-chested breeds go, of course, there are many more than this list. German Shepherds seem to be number one, although Great Danes, depending on what paper you read and how they measured the risk factors, Great Danes you could argue are actually number one. So it's irrelevant. Any large breed, deep-chested dog are prone to GDV. Now, the list factors in the proceedings are very, very long. And to be honest with you, a lot of them are fairly silly. It's not clear at all that they're actually related, like consequential to developing GDV versus just happenstance. But when you look at risk factors for such a common disease that's also complex, there's a multitude of factors, and our job as clinicians to figure out which ones actually matter. So I just cherry-picked a handful here, this list, that makes sense clinically with my own experience with GDVs. Advanced age, what kind of dog you're talking about as far as breed, those that eat a small number of meals a day that could affect gastric motility. Their temperament, most often those are high anxiety dogs or kind of strung out, stress dogs that are easily affected by stress. Any dog that has either stress after eating or they are active afterwards, and we're all aware of the family history of it. There's certainly a genetic component, which at the bottom of this list, there was a recent study that's in your proceedings that actually found 3 genes that might be contributing factors to dogs developing GDV that affect gastric tone and motility. So hopefully we see a lot more genetic related studies in dogs with GDV, because we've always blamed it on genetics, right? We always see it in a specific type of breed. So it'd be great to continue to show that if it's actually true. If they have a history of splenectomy, the risk of developing a GDV goes up to about 5.3 times risk. So 3 to 6% of dogs with GDV have had a history of splenectomy. This is why if you remove the spleen of a dog that is at risk for a lot of surgeons will gastropexy them at the time of the splenectomy because of this future risk factor. You can argue either way on that, and that's certainly a discussion I'm happy to have. But in general, without a history of splenectomy, the dogs that have GDV, it's like 1 to 3%. And so it's certainly a concern if they have a history of splenectomy and they're going to develop a GDV, but it's something to think about. If they have a gastric foreign body, that puts them at 5 times higher risk of developing a GDV, and you could of course see how that could affect gastric motility and cause it. But of course, we see a lot of gastric foreign bodies without GDVs, so it's just a risk factor. And then the deep-chested dogs are a risk. So the etiology is fun to talk about because it's not straightforward. We know that it's gastric dilatation and volvulus, and we don't know whether or not the stomach bloats and then torses, or if it torses first and then bloats. And the story always is, for some reason, the stomach bloats and then torses and you have GDV. Or for some reason, the stomach torses, then bloats, GDV. But that phrase, for some reason, is the problem, because regardless of whether it starts with bloat or torsion, we still don't know what exactly caused it. The same goes for the chronicity of it. We all think of GDV as being an acute or periacute condition, which it invariably is going to be. That's by far very common. But there is a chronic GDV, and there's actually a study in your proceedings that discusses that. And I've always thought clinically that there were a subset of GDVs that I was seeing at specialty hospitals that I considered chronic. And these were the dogs who came in very stable. No sign of distress whatsoever. You collect a radiograph and you have a GDV, and meanwhile the dog's been showing signs for maybe hours, and on physical exam, other than like maybe a distended stomach, the dog's fine. So I believe that there's some of these dogs that I call them chronic torsers, where their stomach torses and then detorses, then torses, detorses. And so I believe there is a chronicity to some of these dogs where if they have inherent gastrointestinal motility issues or what have you, that they are prone to their stomach rotating and then derotating on their own with either no or minimal clinical signs. But we'll see if more studies come out showing that. I do believe clinically it exists. And then whether or not it's actually primary condition versus idiopathic. Most of us think it's idiopathic, but I've seen dogs with GDV that have had a primary condition. For example, the gastric foreign body is a good example. Theoretically, if that gastric foreign body just showed up, meaning they just ingested that foreign body that day or hours prior to presentation, you can call that the primary condition, and the GDV was secondary to that. Or if you have a dog that when you go to operate for a GDV, they have a hepatic mass incidentally there. Well, can you blame that hepatic mass for causing a GDV? Did that cause some sort of spatial abnormality or stretching of the ligaments that support the stomach normally, and that predisposed that dog to a GDV? My point is that when you are working these dogs up, even though you're focusing on the heat of the moment because it's an emergency, sometimes if you look deep enough, you can argue that there might be a primary condition actually involved with them. Laryngeal paralysis is another one. If you have a dog that's suffering from an acute decompensation from laryngeal paralysis, and they tend to be the same dogs that get GDV anyway, and the stomach is bloated because they're aerophasic, and then the stomach torses, well, the primary condition here is laryngeal paralysis. The GDV was an unfortunate secondary outcome. And so I'm not convinced that a lot of these dogs are idiopathic, and hopefully we'll have more studies to show that. Maybe a lot of them have underlying inflammatory bowel disease or pancreatitis that set up the stage for GDV. We'll see. Average rotation is between 180 and 270 degrees, although it can be range from 0 to 360. Typically it's along the long axis, although there's one report of it not being the case. Clockwise direction is typically what you see, although it can be counterclockwise as well. And essentially what occurs is the pylorus and duodenum displaces ventrally and cranially from right to left. So in a clockwise direction, they are positioned then dorsal to the esophagus, and that causes the distal gastroesophageal sphincter obstruction and then pyloric dysfunction. And you end up with this picture here. I'll show you a video later on of GDV, but this is what you end up with your standard GDV in surgery. And so from there, what happens? Well, it's a rapidly progressive, multi-systemic, multi-organ condition that causes compression of the major blood vessels. If you compromise the blood vessels to the intestinal tract, you end up with bacteremia, which is seen in 40% of dogs. This sets them up for sepsis, systemic inflammatory response syndrome, disseminated intravascular coagulopathy, and then as the disease progresses, then bacteremia from liver dysfunction again, due to both the compression of vessels and the compression of the organ, as well as systemic factors, of course. The pancreas gets roped in just by sheer anatomy of where it's located, so pancreatitis is a concern. Up to a third of these dogs are going to have some sort of necrosis of the stomach. Gastric necrosis is a very big deal, and your proceedings goes into a lot of detail regarding what the risk factors for morbidity and mortality are when they have gastric necrosis. And again, because of the anatomy, the spleen gets roped in, and so some of these dogs require a splenectomy. Typically, it's not due to splenic rupture, but due to thrombosis of the vasculature of the spleen. And so the spleen is no longer viable, and it needs to be removed in those cases. And then finally, if the dogs aren't treated, the syndrome hits the heart, coronary flow is affected, and it may be one reason why you see a lot of these dogs end up with arrhythmias. So among other factors, of course, but this is the basic timeline of what happens to these animals once they're affected with GDV. This is your standard presentation. We're all fairly familiar with that. You have a large breed dog, middle age, older, distended abdomen, retching, non-productive vomiting, drooling. So we're going to go through a large grouping of radiographs here, and for some experienced folks, this may be fairly rudimentary. For those who are less experienced or want to learn more about radiographs, hopefully you find this helpful. These are all radiographs I snagged from online. They're not personal cases of mine, but I'm using them to prove a point. So this is your normal lateral radiograph. I suspect it's probably a cat based on the vertebral bodies, the shape of them. But the point is to show you just the importance of the gastric axis. When you're looking at abdominal radiographs, that matters a lot. The stomach axis changes depending on what's happening to the surrounding organs, most notably the liver. If the liver is small, like with microhepatica, the gastric axis is going to shift towards the chest. If you have a hepatic mass or hepatomegaly for any reason, stomach axis will move in a caudal direction. Also to note here in normal radiographs, as a rule, the first gas opacity, just caudal to the stomach, is always transverse colon. Always transverse colon. So that's something that will help orient you when you're looking at a radiograph that seems like a mess to you. If you try to orient yourself that way, remember the gastric axis, and the first gas opacity after the stomach, just caudal to it, is always going to be transverse colon. This is another example. Again, I think this is a cat as well, just showing you the stretching of the stomach. Whether this animal is sick or not, I don't know, but there's granular material in the stomach, and you see how it can distend. It can distend quite dramatically past the causal arch into the midsection of the abdomen here, and then large intestine, right? The first gas opacity caudal to the stomach is going to be the transverse colon, the large intestine. So just showing you again the importance of the gastric axis. I apologize for the poor quality of this radiograph, but I want to show again gastric axis. This is probably a dog based on the vertebral spine. The gastric axis you can see now is been displaced dorsally and caudally because maybe something's going on with the liver. Spleen also lives here. Maybe there's a splenic mass. It doesn't matter. The point is that there's organomegaly that's displaced in the stomach dorsally and caudally. So that gastric axis is important, and so be aware of that when you're interpreting radiographs. Now we're getting into the GDV territory. So again, poor quality radiograph. I have better quality images coming up. But the point is that when you see this Popeye's arm or the reverse C sign, double bubble sign, this is a standard typical GDV. Your right lateral radiograph is the view of choice. And especially if you have a dog who's unstable that you're trying to figure out, do I have to operate on this dog tonight or not? Your right lateral radiograph is going to give you this classic shape. Not always, but most cases this is what you're looking for, is your classic GDV. I also want to point out the importance of looking at the radiograph as a whole. You don't want to ignore the other parts of it. Obviously, the thoracic cavity here you can't interpret it. It's not a well done X-ray. But if you look at the spine, you notice at the ventral portion of the vertebral bodies here, there's bridging spondylosis. So there's spinal arthritis here. And you want to make sure that when you write up radiographs, so you're writing up what you're seeing in totality, don't just focus on the main event. You want to make sure you characterize everything. Also, don't forget, too, the rest of the abdomen. So you can see here there's ileus, which is a very common finding associated with GDV, small intestinal ileus. So you have to note that when you're writing up your radiographs. Another classic GDV here. This one, of course, substantially larger, massive GDV. We're going to talk about megaesophagus here in a minute. You can see the esophagus is a bit dilated. Again, spondylosis of the spine, and then ileus in the small intestinal tract. So classic GDV here. And the reason why I'm mentioning this spondylosis, just so you folks know, it's not the point of this talk, but when you have spondylosis like this, where this entire spine here is fused, Remember, you're gonna operate on these dogs, and they're gonna be on their backs. So not only do you want to support them on their backs while they're in the operating room, but also when you're tying these dogs down on the operating room table, you want to make sure you don't go too taut on their legs, especially the pelvic limbs. I have seen dogs recover well from GDV, but then they're a T3L3 myelopathy or an L4 to S3 myelopathy because we stretched out their spine so much during surgery, not realizing it. You're in the heat of the moment, you're trying to save a life, that you've now sprained their spine. And that's another reason why I'm mentioning this, is these are going to be older dogs, larger breed. They're going to have spondylosis. This is a very arthritic spine. You've got the articular facets here with the sclerosis of the facets. And so you don't want to cause another problem when they're there for a GDV. So leave their legs kind of loosey-goosey. Make sure they're under anesthesia sufficiently enough, because you may end up seeing arthritis on your radiographs. Double bubble sign and ileus as well. So let's talk about megaesophagus, because you're going to see that a lot. So here's the esophagus, and you can see it's dilated. And this happens for a variety of reasons. If this dog is under anesthesia, you can see this with sedation or anesthesia as well. You can also see megaesophagus probably in these cases due to the distal esophageal sphincter obstruction, and also esophagitis from reflux. So those are two other reasons why you can see this. It's unlikely, although not impossible, that this dog had megaesophagus prior to GDV, although it could have. But chances are this is probably related to everything else going on with this dog's condition with GDV. So for purposes of radiographic interpretation, don't forget, besides the obvious, to comment on the megaesophagus, and with the primary rule out being is due to esophagitis or distal gastroesophageal sphincter obstruction. And so GDV, ileus, spondylosis. Another one here. The point of this radiograph, I want to show the crura of the diaphragm. There's your megaesophagus again. The crura of the diaphragm. So you're seeing the stomach here, the gas, but the crura of the diaphragm. Now, when you're thinking about pneumoperineum, which can happen in GDV cases amongst any other gastrointestinal insult, you want to make sure that you are looking for pneumoperineum. And so I'll show you some examples of that. But in this case, this is not pneumoperineum, this is a GDV, and this gas opacity here, that's right by the diaphragm, the crura of the diaphragm, that's part of the dilated stomach. And then, of course, you can see here the diffuse ileus in this dog and spondylosis. So another GDV, just pointing out all the abnormalities there. Maybe poor serosal detail. It's tough to say. This is, of course, where the liver is, and the liver is going to silhouette with the stomach as well as the spleen, so hard to say for sure. Obviously, this is a very narrowed radiographic view. Don't forget to look at the thoracic cavity as well. And again, this is not pneumoperineum. This is the stomach here. Here's a very dramatic GDV where the stomach is basically the entire abdominal cavity. So that's pretty dramatic. And these look a little different, right? It's a less Popeye sign, less double bubble, more just a really large fluid and gas-filled stomach. So you also want to go based on the history, go based on your physical exam findings, possibly other views if you need them. And this is the point of this slide, is to show you the other views. So we always rely on the right lateral, which is this image here. The right lateral gives you that beautiful double bubble shape, confirming the pathognomonic finding for GDV, and then you can look at the entire abdomen as you should. But sometimes the clinician or your support staff are not aware that what views you wanted, and they're trying to get through these radiographs as quickly as possible in an unstable patient. So you may end up with a lateral view, a left lateral abdomen rather, sorry. Or you might end up with a VD view or a DV view, right? This is all the same dog, but you can see how the stomach changes as you're going from right lateral to left lateral to VD. So if you went based on left lateral first, and maybe you're an inexperienced clinician, you're a new graduate, you're a veterinary student, you might look at this and think, well, okay, that's a dilated stomach, I guess. Maybe he's got gas bloat or food bloat. There's nothing too crazy in the abdomen here. It's fluid-filled, small intestines, not all that ileus that we were seeing before. Maybe this is just a medical treatment, maybe even an outpatient. But if you were to collect your right lateral radiograph, you'd be more convinced, oh, this might actually be a GDV. And then the VD, of course, just shows a massive stomach with both gas and fluid in it. So 3 views, unnecessary to diagnose GDV, necessary if you're trying to be as thorough as possible. So you have to weigh the pros and cons of the additional views with a critical patient, but I just wanted to show you how it changes depending on the views that you've collected. Pneumoperineum. Now, at the end of the day, if you have a dog with GDV, regardless of whether or not it's got pneumoperineum, doesn't really matter, because the solution for these dogs, the treatment of choice, and the only treatment, is going to be surgery, exploratory laparotomy with possible gastropexy. So you're going to be operating anyway, and if there's a portion of the stomach that actually has necrosis and is ruptured and there's pneumoperineum, if you do a thorough abdominal exploratory, you're going to find that area anyway in the stomach, or rather in the abdominal cavity, when you explore at time of surgery. So it may not matter, but just to be thorough, because pneumoperineum can be very tricky, and not every GDV is classic, and sometimes you're looking for a GDV and you collect your radiographs and it's not a GDV. So just to give you an idea, in case you've never seen pneumoperineum, this is what it looks like. This is, of course, a very severe version of pneumoperineum. Your first clue is that there's gas surrounding the abdominal viscera, so that's of course abnormal. And also the second thing is you're noticing that you can see the detail of the viscera very clearly. I mean, these are a beautiful outline of large intestine, small intestine, stomach, liver. It's gorgeous looking because the air is outlining it. And then third, the crura. Now notice that when you look at the diaphragm, both the crura of the diaphragm here, very well delineated, nice thin stripes. Whereas on the previous views, you have a thick crura here, and you have this gas of the stomach that's abutting it, right? That's different than what you're seeing with pneumoperineum, where you can see that the outline of the diaphragm here, very thin, powerful muscle, but very thin muscle, and the air is accumulating. And because the crura, especially if you're in certain lateral positions, they're never on top of each other. One is going to be in front of the other, and so you'll see the outline of the crura there. Now, it doesn't matter again in this image, because this is a very obvious pneumoperineum. But maybe you have something more like this, where again it's grainy and it's focused. But something like this, where it's not as obvious, you have a very thin diaphragm here, and then you've got an air opacity here, and you might say, well, that's just part of the chest, which it may be, but it's also very suspicious because the diaphragm is so nicely delineated. So you wonder if there's pneumoperineum in this patient. And same thing here as well. You would look at this and think, okay, well, this doesn't look like a pneumoperineum just off the bat, but this is where air first accumulates in pneumoperineum, and it outlines the diaphragm very nicely. And so you can see the muscle there of the crura. So put it together with history and physical exam findings, of course. It's never going to be necessarily a slam dunk unless it's severe pneumoperineum, but this is the section you're looking out for. So just keep that in mind. Don't forget to be very thorough when you look at radiographs, especially at this corner here. And then here's just an example of what probably is maybe mesenteric torsion, maybe colonic torsion. So not every large gas opacity in the stomach or dilated viscera, gas-filled viscera in the abdominal cavity is going to be a GDV. There are other reasons for it, less common reasons. Here's a mesenteric torsion, and so there you go, right? It's not always going to be a GDV, and whether or not it changes what you talk about with the owner, it probably will, but keep in mind there are other things that can cause acute severe dilation of the gastrointestinal tract. With clinical signs, they may resemble that of a GDV, and it may be in a breed that's typical for GDV as well. So just to show you other reasons why you'd have severe abdominal distension. And then because we never really see ventrodorsal views with GDVs, I figured I would just show you a collection here of dogs on their backs with GDV. So this is what they typically look like. It resembles somewhat of a heart, but this is what you're looking at for that. And then the last thing is, you don't necessarily want your GDV to end up in CT scan, which can happen. So here's a CT of a GDV. I bet you this is probably one of those cases that were a chronic GDV, meaning came in fairly stable. Maybe when they took their preliminary abdominal radiographs, it didn't show a GDV, the dog derotated itself. But because they want to do a workup, they collected a CT scan, and then the dog maybe happened to bloat somewhere between anesthesia and the CAT scan unit. And so this is an axial view on CT scan with a severely distended, fluid-filled, and a little bit of gas stomach. And then here is the ventrodorsal view, or the coronal view of the same dog with a large distended stomach here. So GDV diagnosed on CT scan. It can happen. Obviously, you want to catch on radiographs, but sometimes these cases can be quite tricky. So before we go into what to do next with GDV, we are going to touch on vet triage now, because this is the pivotal moment. You have a dog who's critical, they're ill, you need to act fast, you need to try and diagnose what you think might be going on in that moment, and then you have to talk to the clients. and you have to talk to the clients about everything, what you think's going on, what the options are, if there are any other options, what the price is going to be for this, what the possible complications are going to be, what's the prognosis. So this is where a platform like ours comes in handy. And just in case folks are not that familiar with Vet Triage, it's a 24/7 video telehealth platform. This is an example of a flyer that we create for one of our partners. This is, of course, Cornell University. They've been using us for years. We create a flyer that explains to their clients what we are. Here's how you connect. Go to their landing page. They can use the QR code. Here's a landing page again. And basically, clients can talk to a veterinarian on live video 24/7, English and Spanish, to receive tele-triage and tele-advice. That's the goal here. Here's another partner of ours located in Hawaii. They have a beautiful website, and if you look if you scroll down to the bottom, it's got after-hours services here, and then there's a Vet Triage logo, a summary of what we do. Click on this button to talk to the doctor. So when they click on this button, the client will then get to the landing page. This is a hospital in Idaho. The landing page has their logo on it, another description of what to expect, and then when they scroll down, there's the fields to fill out to create their account. And so when they create their account, all we're asking for is email, first name, last name, phone number. They choose English or Spanish. And then if it's a horse, yes or no. Horses have a different price point. And also we want our equine doctors to handle those cases. So the client has to tell us whether or not this is a horse they're worried about. But we want to get the client on very quickly, and that's why there's no information here on signalment, chief complaint, anything like that. It's purely let's get them on with our doctors right away. They click the button to pay. This is for equine, that's why there's a horse there. It's $75 for horses, $50 for non-equine. They click the button and they're on with our doctor. And so that's on the pet owner perspective of this. For Vet Triage, they get triaged on live video, given advice. Either you have to go to the emergency hospital or not. And if you don't, which is the majority, we're going to give them advice and monitoring parameters for home care. So for Vet Triage Pro, we decided to go with on that platform. It's Pro. We launched it earlier this year at VMX. We announced it publicly, and it's telementoring, teleconsulting. And so I'll play this video, and I'll talk as it's going on. So. The gentleman there is one of our Vet Triage doctors. He's talking to a fairly new clinician. This is a TPLO follow-up case, but the point remains that with Vet Triage Pro, the goal is to give anybody who's listening and watching this webinar the ability to speak to a seasoned doctor about a case without necessarily requiring a specialist involved. You're looking for guidance, mentorship, consultation on a case that you're confused or you don't know where to go with it. Maybe it's a client communication challenge that you're having. Maybe it's a case workup challenge. Maybe there's an anomaly on the blood work that you're not sure about. In this case, we're watching the patient here walk. I think he's maybe 2 months or so after a TPLO surgery. So we're assessing the gait on live video with our doctor on the Vet Triage Pro platform. And the clinicians that want to use Vet Triage Pro for telementoring, teleconsulting have the ability to even upload radiographs and blood work ahead of time so our clinicians can look at it. Or as you saw here, she'll show the doctor on the screen the radiographs on their viewer. So whatever makes sense for you as a doctor or a veterinary student to use our Vet Triage Pro platform. You now, if you're stuck with a GDV and it's your first one, you're not really sure what to do, how to talk to the clients, how to proceed, you can run a case by one of our seasoned veterinarians and get their advice on what to do. And that's the point of Vet Triage Pro. We know from recent surveys that what used to be the student debt and being sued were the top two concerns of veterinary students and new graduates has now flipped over the past couple of months, or I should say maybe 6 months plus, to now their major concern is mentorship or lack thereof, and then of course work-life balance. And debt and being sued are still concerns, but now it's flipped to where they're really worried about mentorship. Can I get help when I'm out there alone? It's the middle of the night. I don't want to call the hospital owner. Maybe I'm an intern. I don't have any backup. Maybe you're a solo practitioner. You've started your own practice. You've bought into a practice, and it's only you. You want to phone a friend. You can talk to one of our seasoned veterinarians. And the best part about it, beyond the mentorship aspect, is the costs can be either taken care of by your hospital group or the employer, the hospital owner, or you can even pass that cost on to the client as a teleconsulting fee. And that way, because revenue does matter in veterinary medicine and any business, you want to make sure you're not losing money on this. And with mentoring like this, the goal is to eventually have you not use this anymore. So as a doctor becomes more and more seasoned, as the years pass by, you will find yourself using a platform like VetTriage Pro less and less. So this cool interaction in real time, online video between seasoned veterinarians and a new grad or a veterinary student or an intern it's built, it's ready, it's been helping lots of folks in the vet field, and so you can have this type of relationship. And then the vet triage doctor will email you a summary of the advice given, the consultation. And then for the next 7 days, you can consult with our doctor with any questions or follow-up you have, and they'll answer your email. And that way you can have reassurance that not only you're getting help in real time for whatever it is, but you're also able to follow up and get further assistance from there. So novel platform to help folks who need that type of mentorship. So think about that, especially when dealing with a common complex disease like GDV or any other medical condition. And then from there, you're gonna go talk to the owner. And when you talk to the pet owner, we know that the majority of communication is nonverbal. It's how your tone is. It's how your facial expressions are. It's your body posture. Everything about it is felt in the room. Verbal only makes up maybe a third of the communication. And so when you are in the room with a client, especially they're distressed, it's the middle of the night, they have a GDV, and you may be talking about euthanasia, if they're not going to dive into surgery, whatever it may be, you want to be in a position to poise yourself to where you are giving that client the utmost confidence. So here, for example, you can see the doctor, they are sitting at a level lower than the client. I love that. I think that it's a way of the power dynamic being in favor of the client. You want them to be in charge. I wouldn't have the dog on the table while you're talking to them, so I'd have the dog on the floor. Here's another example, dog on the table, not necessary. If you're gonna talk to the client, have the dog comfortable, maybe walking around the room or on a leash or something like that. Of course, if you still use film, most of us don't nowadays, but put it on the box, on the light box. You're not going to hold a radiograph like that to show a client. And the standing up, it also is, you're not giving a sense of comfort. It's a very stringent environment. Even though she's smiling, he looks confused or annoyed or distressed. You want to be in a more relaxed state where you can talk to a client as if you're talking to another human being, because that's what they are. They have to make a very human decision tonight. They have a GDV and they are freaking out. This is a nice picture. You have the doctor sitting on a chair, the client is sitting, dog is relaxed. I'm not sure I'm a fan of the face-to-face part of it. I prefer something more conversational, side to side. Side to side is really good. And in fact, when you're on the same side as the client, both sitting down, you are now on the same team, and the patient is the focus now. It's not patient and client versus the doctor. It's doctor and client evaluating what's best, the best interest of the patient. These things matter. It resonates. Here's another beautiful view here. He's relaxed. He's below eye line from the client. Dog is fine. We're going to have a nice conversation, even though it's about a serious topic. It's going to resonate as, let's talk about this. I love things like this, sitting side by side, showing the client the blood work or the radiographs on your iPad, showing them, letting them peruse through it. It's their pet, and they're the ones that are going to make decisions. Let them ask questions about what you're showing them. And then this is another example, show the x-rays or show the estimate. Maybe the doctor is going over the estimate for this client. It's going to be a $10,000 bill for a GDV, right? You have to call in the surgeon or refer them to an emergency hospital, specialty hospital. It's a big moment, not only for what's the best interest of the pet, but also it's going to be hard on their wallets, right? And so you want to be in a position where you are in a relaxed state. You're not overpowering the client. The power is in their hands to make a decision. It's informed, and you're showing them scary radiographs, scary blood work, a scary estimate, right? And so you want to make sure this interaction is as positive as it can be, considering the scenario. So when you talk about spectrum of care, this is what we're talking about. Perspective taking and seeking also require us to draw upon cultural humility and recognize our clients view their patients' care journeys through a unique lens, may be influenced by personal, familial, cultural, and societal perspectives on the relationships with their animals, the function and inherent value of the individual patient, as well as the uniqueness of their bond. It's huge. It's a great way to summarize, your job as a clinician is to tell the client what you think's going on, what their options are, pros and cons of those things, including costs, and then let them decide what they want to do with reservation of your judgment of their decision. So veterinary factors, client factors, pet factors all play a role with communicating with clients. So let's get back to our GDV. You have a GDV, you've diagnosed it, and now you're trying to balance stabilizing the pet, taking them to surgery, but also talking to the client about all the things that I've mentioned. And from left to right, from red, orange to green is a basic skeleton outline. We're gonna go into more detail here, but all these things initially on presentation, you're gonna be kind of juggling at the same time. The client communication aspect has to happen throughout this. They have to authorize things that you're going to do. So IV catheter placement, basic blood work, whatever radiographs you think you need. Let's check some vitals. So blood pressure, TPR, ECG. Do you think this patient's in shock? Fluid therapy. What's the temperature? What's their oxygen levels? Are they in pain? Do they have to be sedated for decompression or sedated for radiographs? What do you need done with them? And this is all happening while you're talking to the client, getting at a minimum verbal authorization, if not ideally written authorization for what you want to do with their pet in the next 30 minutes. This is all happening upon presentation to your hospital. And then step 2 with the GDV will be something like you're telling the client, okay, I've got the diagnosis based on the first series of workup. I know what's going on. Here's the estimate of what's going to run. In the meantime, should I start tubing this dog? Do I need to trocarize this GDV? I'm starting to think about anesthesia, prepping the OR. Am I in a facility that requires calling in a surgical team, or am I going to refer this case after stabilization? And then you're following up on what you found on the first tier of plans. And again, this is very basic. I'm sure folks looking at this list thinking, well, what about this and that? This is just a skeleton just to give folks who are not as experienced with how to tackle a complex critical case. It doesn't matter whether this is a GDV or a pyometra or acute renal failure or a cerebrovascular accident. It doesn't matter. It's the same idea, is that you're going to go with stages. And the final, of course, is going to be taking care of that pet more definitively. And this is just getting to the surgery. This is the anesthesia, surgery, post-op recovery. Then you're talking about nutrition, elimination, comfort level, all that stuff. And then they're in the hospital. And so think of these things happening. And part of part 3 is also to revisit things from part 1 and part 2. You're going to keep revisiting, and client communication happens throughout this process, especially in the beginning periods where maybe it's a bit hairy for the patient. Now, your proceedings goes into stabilization with a little bit more detail, but even that's a whole nother talk on its own. So just some basics here. There are plenty of studies that compare various compounds being administered to animals that are in shock that you can consider. It depends on your experience level, what studies show, what do you have available to you in that facility, what the case demands. So it's a complex topic, but you're trying to get fluids into these dogs as fast as possible while also considering the importance of gastric decompression. I've never been a fan of trocarization of the stomach, because to me, looking at the gauge of this catheter compared to a Great Dane who's like 190 pounds with a huge stomach, I just remain unconvinced this is going to be substantial. But I have definitely seen doctors do it, and I know plenty of doctors listening and watching this would say, no, I disagree, it's been very effective, so go for it. Of course, I, of course, am a surgeon, so I'm looking at, well, can I just decompress the stomach instead of trocarizing them, because eventually I'm going to have to anyway. Whether you do it pre-op or post-op depends. Depends on the status of the patient, depends on who you have access to as your veterinary team, depends on who's cutting the case. As a surgeon, I don't have a strict rule on that dog has to be decompressed before I get there. I'm going to get to the hospital as quickly as I can once the client approves all the workup, the treatment, and the estimate. And then if it's not decompressed by the time I get there, I'm going to decompress them. And I'm either going to decompress them before surgery or in surgery. Just depends on the situation. And so this is just measuring the orogastric tube, typically to the last rib. Folks are afraid of penetrating through the stomach wall, right? If there's gastric necrosis and you go through the stomach wall, then what? Well, my answer always has been, who cares? It doesn't really matter, because if you penetrate through the gastric wall, it already has necrosis. And if you're talking to the owner about surgery, you're going to go into surgery anyway. It's not like you're going to decompress the stomach and you inadvertently, accidentally, and unknowingly ruptured through the stomach, and then you sent the patient home. That's a different scenario. That's not going to happen. So I'm more concerned about getting this tube in the stomach, and less concerned about gastric viability, because I'm going to go cut this case. And the gastric necrosis was so bad that I was able to penetrate it with an orogastric tube. It was going to need a gastric resection anyway. To me, that fear just doesn't really matter. But for a clinician who's less experienced, if you're going to go based on landmarks, which is what you should be doing, the last rib is typically where you're going to measure. So you measure to the last rib, place a piece of medical tape there, and then you can insert it into the stomach. Now, some dogs come in so badly affected, they are so lethargic or even comatose or obtundant, you can even maybe do this without any sedation, because they're that debilitated from GDV. So this is showing somebody who believes they can pass an orogastric tube in this dog who's awake but debilitated. You put in a roll of medical tape in there and pass the tube through the tape. That way, if they do respond to it, they don't bite down the tube, and now you have a gastric foreign body. And then here's in surgery, passing the tube. Sometimes you can't pass the tube because when the stomach torses on itself, the distal esophageal sphincter is so taut that you can't penetrate through it. And so you have to go into surgery and manually derotate the stomach. And then as you're derotating the stomach, your technician, your assistant, is passing the tube. Sometimes that's required. But most cases, I would venture to say you could decompress before going into surgery. But again, it depends. So this is a video showing how the GDV forms. And so you'll notice if the dog's on their back, the dorsal recumbency, and if you're standing at the dog's hind legs and looking into their abdomen from the caudal perspective, you'll notice this clockwise turning. So the pyloric antrum here is turning clockwise direction. If you're standing caudally as the dog is in dorsal recumbency, like in surgery, and you notice that the pyloric antrum flips over. There you go. And then the fundus and body flip the other direction. And now you have your GDV. You can see how it's going to cause an obstruction of the distal esophageal sphincter and wrapping the omentum. Also notice that the spleen is involved as well. There's a spleen, and it's going to be involved too. So now in surgery, your goal is going to be, assuming that the degree of rotation in this video, which is probably 270, assuming this is what you end up seeing in surgery, you now have to reverse this. So if you're the surgeon, and in standard fashion, most surgeons are going to stand to the right of the patient if you're right-handed, and so you're standing here and you've made your abdominal incision. Your hand is going to go around this direction here, and you're trying to grab the pyloric antrum. You're trying to grab it from underneath, and so if you're able to grab it, let's say we've got it. Now your hand moves this way with the stomach and pulling the stomach ventrally, so up towards you, up through your incision basically, so the stomach can derotate. At the same time that you're doing that with one hand, your other hand is putting downward pressure on the distended stomach. It's going to help you rotate that stomach because you don't want to cause any trauma. And remember, you're pulling from this side blindly. So you want to gently push in the stomach that's distended while you're grabbing the pylorus and detorsing the stomach. Obviously, this is something you have to practice in real time, but just to give you an idea. So you're in surgery now, and you'll see various conditions of the stomach. Here's an area that's a bit questionable as far as necrosis. This is the probably congested spleen. Is another congested spleen here, and so you have to decide: do I have to remove a portion of the stomach or not? Does the spleen have to go? I have to do the rest of my abdominal exploratory as well. Is the patient stable? You're balancing all of these things. Don't forget the importance of Balfours. Abdominal Balfours, self-retraining retractors, very important, especially if you don't have an assistant. But even if you do have an assistant scrubbed in with you, Balfours will open the abdominal cavity for you so you can visualize it and then perform your PECSI. Your proceedings goes into detail about the different approaches to this and what type of gastropexy you can perform. These are just some examples of common ones that have been reported. They have the belt loop, the muscular, circumcostal. So most of us are going to perform an incisional gastropexy, which looks like this. This is a laparoscopic procedure, but this is what you're looking for with incisional gastropexy, as attaching the stomach just before you get to the pyloric sphincter and attaching it to the right lateral abdominal wall. And obviously with a scoping procedure like this, which is very cool to do prophylactically, maybe you're doing it at the time of the spay or the neuter, but you're not going to perform a scoping procedure like this in an actual GDV. You have to decide with a GDV, what am I going to do? And with an emergency GDV, you're going to have to go in there and derotate the stomach. There's no scoping way of doing that as far as I know. You have to perform an abdominal exploratory, derotate the stomach, and then figure it out from there what your exploratory shows. Whereas a preventative measure for GDV could be an open approach, like a laparotomy, as you see here in this picture, but it also could be a scoping if you're proficient with laparoscopy. So keep that in mind too. Not every single technique mentioned that you read about is suitable for a GDV. And then this is the end result with a standard open GDV, a gastropexy here. This is beautiful. That's what you're looking for, and this is what you're creating. You have an incision over the gastric wall, a matching incision, abdominal wall, and you're suturing them together. You're going to start with usually you're going to start, in my opinion, the cranial end of that incision, so the closest to the diaphragm, and then moving caudally, and you're starting with the lower incision, the deeper incision. So from cranial to caudal, the deep incision gets sutured first, and that way you still have adequate visibility of the more superficial incision, again starting cranially by the diaphragm and then moving caudally to finish it up. If you did the reverse and you started with superficial incision, now trying to suture the deeper one, you've now caused an obstruction of your visual capacity, and that's going to be annoying, very frustrating. So, and then one more thing I want to mention here too, because a lot of folks are not fortunate enough to have an assistant in the OR like I usually have. The using a sharp towel clamps to hold up the abdominal wall if you're alone doing this procedure, very, very helpful, because when you're going to perform your gastropexy, you have to remove the self-retaining Balfour retractors. Otherwise, it's going to stretch your pexy and your anatomic landmarks are no longer going to be accurate. So you have to remove the Balfour, but you still have to perform abdominal surgery in a deep-chested dog. So you still have to have exposure. So you take a towel clamp and you apply the towel clamp to the side of the abdominal wall. Avoid the skin. The skin is contaminated, just the abdominal wall. And then you can use one hand to retract on the abdominal wall, right? And then on the other hand, you're now suturing your gastropexy. Obviously, it takes experience to do this. Over time, you'll get this done, but I just wanted to show you the value. You don't necessarily need an assistant. Very helpful to have one, because then they can do this for you. They can open the abdominal cavity or hold the stomach for you or whatever you need. But if you don't have an assistant, this is a great way of providing self-retraction. Complications, there's a ton of them, and it's been reported up to 76% of dogs will have complications, anything from kidney injury to hemostatic derangements, cardiac arrhythmia, splenic thrombosis. There's a whole list in your proceedings regarding this. And VPCs, ventricular premature complexes or contractions, are the most common thing that I'm looking for. You can see this pre-op, intra-op, or post-op. And so it's one of the biggest things that give veterinarians angst is VPCs. And so it's a very common one that I'll talk about in the next slide, but there's a whole list of complications you're looking out for. And this essentially is what you're talking to the client about in brief, especially the more common things like your dog may lose a spleen if it's not salvageable. We may have to perform partial gastrectomy. Cardiac arrhythmias are a concern as well. And so those are the things to talk about with clients, amongst other complications to consider, while you're also against the clock because you have a patient that's critical. This slide is meant to show the dangers of working on a dog who's critical and is also obtundant and geriatric. Bronchopneumonia. So this is a ventral dorsal view of the thorax. The head would be up here, and you can see consolidation of the cranial lung field with an air bronchogram here, and that's classic bronchopneumonia. It could be other things. This could be blood or anything else, torsion, tumor, whatever. But for our purposes, this is bronchopneumonia. And then when you have the lateral thoracic view, the head is over here to the left, the tail is to the right, and then you're seeing here consolidation of the lung lobe along with an air bronchogram. See that? And so that's, again, cranioventral distribution of consolidation, number one on my list, especially in a patient who's post-op from a GDV, who's geriatric and obtundant, maybe obese and just not moving around a lot, bronchopneumonia. And so the importance here is to get these dogs up and moving after surgery so that you don't get pneumonia, because that's a concern, a very common one. Mortality has a wide range. Survival, of course, pretty good with surgery, not so great without surgery. There's many factors that influence mortality. And the reason why you care about this is because you're going to talk to the client about what factors you're thinking when you're going into, well, do we invest $10,000 in our 10-year-old Great Dane, right? That's a valid question to ask. And the answer is nobody really knows unless you try. Here are things that I'm seeing that are of concern that may help you make a decision, right? So your proceedings have way more detail than this, but how they present. If they present to you in a coma or obtundant, they have a high risk of having issues post-op if they require a splenectomy. One of the biggest factors that affects mortality is gastric necrosis. I mean, I have yet to see a dog do well after a gastric resection. If they survive the procedure, they have a rough recovery. It's a tough one, and I don't know why, other than maybe saying that the GDV was so severe that the gastric necrosis and a manifestation of a systemic problem like SIRS and DIC and all those acronyms. So maybe it's just a representation of more severe disease. Maybe it's not actually the surgery of removing the stomach, a partial gastrectomy, but maybe it's more of just that dog is really sick and the really sick ones have gastric necrosis. I don't know. Lactate concentrations, a whole host of literature in your proceedings about that. We're not going to go through all those numbers. They're there for your reference. But lactate concentrations, both on admission, as they change during hospitalization, what they are post-op, etc., also may affect mortality. So this is the reminder of our stages here. And this is your typical, what I would consider like a pretty standard treatment sheet post-op for a dog who's had a GDV. You're monitoring the vitals. You want to make sure that they are not gaining weight from fluid overload. You want to watch them carefully and constantly monitor them. I want to talk about lidocaine and procainamide. Every hospital is going to have a different way of doing this. If you're seeing arrhythmias and you're trying to correct it, most of us will start with a bolus of lidocaine, and then regardless of whether or not they convert, the rhythm converts to normal sinus rhythm, you're going to get them on a CRI, continuous rate infusion. Then usually, but it just depends on the surgeon and depends if you have internal medicine doctors around or your own experiences. Then I've started procainamide intramuscular initially because they're not eating right away after surgery, and then eventually orally once they're eating. And then my goal is to get them off lidocaine. Lidocaine is not benign either. It causes neuromuscular weakness, it causes ileus and nausea and appetence, and these are old dogs, they're debilitated. So any type of nutrition you can get in them, you want to, and if they're becoming neuromuscularly weak from lidocaine, that causes them to be recumbent, bronchopneumonia, all of those things happen. So I start lidocaine as a bolus, then a CRI, and then I begin with procainamide because that's not going to work as quickly as lidocaine will, and then eventually get them off lidocaine. You don't have to wean them off lidocaine, by the way. You can stop it. I still, admittedly, will wean them off, but you're not required to. Most of us do that because it makes us feel better, but you're not required to. So I usually will start at whatever dose it is, maybe even the highest dose, just depends, and then cut down by 50%, and then maybe another 50%, and get them off of it as quickly as I can. Or if you're seeing a dog who's post-op that's throwing occasional VPCs, well, then the question is, when do you treat them? And that also depends. For me, my general rule is if you're seeing one ECG strip that's got 30% or more of that strip VPCs, then I'm going to treat. Or if the dog maybe doesn't have up to 30% VPCs, but it's clinical for the VPCs, meaning drop pulses, pale gums, weakness, lethargy, all the classical clinical signs, and I can't attribute those clinical signs to anything else, then it might be the VPCs, and I'll start treating for that. And so you have to use your clinical judgment and your experience, not just look at the ECG strip and think that every single VPC is worth treating, because they're not always the case. And then, of course, there's the other treatment plans here that you can look at as well, all fairly basic for any post-op patient. And then finally, to end on some key points, prevention is ideal, of course. If you have the dog, it's at risk for GDV. You want to get them pexied at the time of their neuter or their spay or dental or whatever it is. Maybe they're having a gastric foreign body surgery and they have not been pexied before, so we can pexy them at that time, possibly. Just talk to the client and decide what they want to do. What's cool also about prevention is that for doctors who want to cut GDVs but are not experienced with it, And for clients who understand that you're going to try this, if you're going to spay their dog anyway, see if they'll let you try a pexy on their pet. Be clear and transparent about your experiences. But since you're going to be more affordable than a specialist, and it makes sense to pexy them at the same time as a spay, and the client understands all of this, it's a great way to practice your pexies. It's a fairly benign surgery. Start with cadavers first, and then once you're ready to move on to a spay and neuter scenario, it allows you the ability to try and pexy. And then when you have a GDV, you won't be as timid or as scared to perform the pexy in a GDV case. Remember that a chronic does exist, but acute is of course more common. Don't forget that there may be a primary cause for this, so look at your workups carefully. Gastric resection we didn't talk too much about as far as delaying it. What I recommend doing, if you see a portion of the stomach that looks questionable, maybe don't perform the partial gastrectomy yet. Perform your gastropexy and your exploratory and everything else, and then look at the stomach again. Sometimes that area that's questionable revitalizes. So just keep that in mind too. If you remove the spleen, submit it for biopsy. If you have an older dog that's undergoing a GDV, I always biopsy liver, even if it looks normal, because they're older pets, and a lot of the same breeds that are prone to GDV are prone to hepatic pathologies like neoplasia, so I biopsy them. And then any concurrent surgical procedures during the gastropexy is up to you. If you have a dog that's got a GDV and, by the way, bladder stones, or a GDV and, by the way, mammary gland tumors, do you perform the elective procedure or not? And so that's a procedural question, an ethical question of what to do. For me, in short, I tell the client, I'll do the cystotomy if after the pexy is done, your dog is still okay under anesthesia. Otherwise, I reserve the right to abort mission. And most owners will say, sure, that makes sense. Yeah, if you think my dog's in trouble, do the thing that saves their life and then get them off the table. We'll do the cystotomy later, where at our regular vet or with you in a few months or something. So talk to the client about that. And then finally, a reminder about Vet Triage Pro. We welcome the opportunity to be a part of your process to become an experienced clinician from vet school into graduation, maybe your internship. We'd love to help you out. This is huge for the future of our profession, to make it where doctors can love being doctors and feel comfortable growing into the role that they intend on being in. So with no further ado, this is my my contact information, both for myself and for Vet Triage. Feel free to reach us out with any social media platforms or email. And thank you again, AmeriVet, for setting this up. Thank you, Ashley, for making this happen. And if there's time and folks have questions, I'll be happy to tackle anything you've got.
I do have some questions. I just want you, if they're in for Vet Triage Pro, if they're in the procedure and have a question of what they're doing, say they've made it this far, they can call and video live streaming what they're doing in the OR.
Absolutely,
correct?
Yes. In fact, I would say probably that may be like top 2 or top 3 indications for using us. We've had folks call us in the middle of a foreign body surgery or a mass removal. There's some bleeder like by the liver they're not sure what to do with, and so they'll video us because it's a live video platform. And as long as you have somebody who can point the device at the area of concern, we can help you in real time with that surgery as well.
Okay, awesome. Real quick before I get into the questions, we did change the way our CE certificates are coming out. They are coming from a different platform. I believe it'll say AmeriVet is sending you something. It's called by SimplyCert. Bryn and I are also sending you guys follow-up emails from the learning and development email, letting you know that we sent the certificates out and to look in your spam folder. So the CE for this actually is not coming from us, but it will probably, I'll give them a couple of weeks for Zomedica is going to get this out. So this one's not coming from us, but in the future, all the other ones that are coming from us, you'll get a message from that. Okay. So we do have a series of questions here. The first one is there a standard way to look at different x-ray views and have a system to provide a prognosis for survival to share with the client making the decision to go forward with surgery? Or is it just, I'm going to say it says, or is it just poor? And I'm going to assume that means diagnosis or something along those terms.
So let me know if I'm understanding it correctly. The first part of that question is in regard to positioning for radiographs. And I would say that if you have a dog whose history and physical exam findings presentation is suggesting a GDV, your right lateral is going to be the first way to go, and you don't necessarily have to complete the series. If that's enough to give you an answer, and that at least gives you enough information to talk to the owner preliminarily about, hey, this is a serious condition, we need to finish our workup and also go to surgery tonight, here are the pros and cons, then you could clinically stop there. I typically want to collect the other views later on, but it depends on the scenario and the client. So I don't know if that answers the first question with the positioning.
I think he's thinking of, is there a way you look at the radiographs? Do you always start at where the esophagus meets the stomach, running the GI tract, then circling back out to the rest of the organs? Like, how are you scanning it? Do you have a system in the way you're scanning it?
Yeah. So let me see if I can. Okay, there we go. So it's very important with everything you do, whether it's radiographs or surgeries or whatever, that you do things in the same way all the time, because that eliminates your risk of skipping steps, right? So you can read radiographs either going from cranial to caudal, kind of like how I was hinting at. You can read radiographs from going inside to outside the body. You can also read radiographs by starting with bony structures, then going to soft tissue, or starting with soft tissue and going to bony. I don't care what you do. The only standard that I'm aware of is do the same thing all the time. And so I'd like to think that I do that. As you get more experience, you tend to do that sort of innately, right? But in general, yeah, that's the way we all look at radiographs, is the same way repeatedly. Whatever it is you choose, do it the same way all the time. And maybe your technique is different for a lateral than a VD, but the same way every time is how you want to do that. Awesome. And then I'm not sure about the prognosis question with that one as well.
I think he followed up on it. Is there a survival rate prognosis?
Yeah. So your proceedings has all that information in there as well, but that was the intent with this slide. The last one was survival can get up towards, like, here it is, 75 to 97%, very wide range, but a high survival rate. Whereas without surgery, 80% will recur. Half of these dogs will recur in the first 3 months after developing a GDV. And for those who actually don't die immediately or shortly afterwards, 80% die within a year from no surgery. But yes, this is the survival rate, generally speaking, for PEXI after a GDV.
Okay. The certificates, if you did not receive the certificates, please send me an email. They are going to the spam folders for a number of people, so just double check that and just let me know what webinar you think that you need it for. Okay, the next question is, when GDVs occur, what is the time frame in hours from noticing symptoms to high complications, possibly death?
Ooh, love it. So what we did not go over, but is in your proceedings, is actually studies coming out now comparing immediate intervention versus delayed. And by immediate, depends on the study, right? But typically when you think of immediate, you're thinking of like within the first 2 hours of presentation that you're stabilizing this pet and going into the OR, right? On average, like 90 minutes, but let's say 2 hours. Waiting, delayed, is after that. Could be up to 10, 12, 15 hours post presentation to the hospital. And so we need more studies. I put the numbers in your proceedings, but it's showing some promise with some of the characteristics of a GDV's progression, that delaying it may be as beneficial as intervening early on. So you could. I've also known surgeons, this is anecdotal, that will decompress the dog. After decompression, place a nasogastric tube, wake the dog up from the sedation they use for decompression, and then continuously decompress them from the nasogastric tube, they're awake, overnight, so you can stabilize them further, and then cut them the next day. And I've heard claims of that lowering the rate of gastric, the need for partial gastrectomy, and maybe a better outcome. But again, that's not studies, that's just talking amongst doctors, surgeons about that. So that also I've heard of before too. So we need more studies on it. I think I wrote up 2 studies in the proceedings that looked at that. So we'll see. But yes, there is promise there for, because it originally was thought, to what you're alluding to, is the longer you wait, the worse it is. And that is actually a risk factor for mortality. The longer the dog has clinical signs, presumably at home, the more likely they are to have complications and die of the disease, or after surgery, or needing a gastrectomy, or needing a splenectomy. So in the hospital, though, under monitoring and aggressive treatment, it may be that you actually might have some time. We'll see what the studies show in the future for that. Great question.
Is there any studies for the time frame for before they get to the hospital? And that probably is likely to depend on if it's a partial torsion to a complete 360 torsion.
Yeah, if because one of the factors to mortality rates is how severe the torsion is, and whether or not, again, spleen and stomach are involved, because they also affect mortality for these dogs. I don't have a cutoff for number of hours. I don't know why I'm thinking 2 to 6 hours is like somewhere in that range is the cutoff, but I don't know. I'd have to look at the notes and see if somebody ever published like a cutoff time. I don't know. But in general, based on studies, the longer the client waits, the worse it is.
Okay. The next question is, if a dog is predisposed genetic or breed-wise, would you recommend owners to get wall tacking done prior to diagnosis? So you did talk about PEC-ing prior to doing that. Okay.
Yes, and even though I've seen dogs that are not classically ones at risk for GDV develop GDV, like I've cut like Cocker Spaniels and things like that with GDVs, it's not customary to PEC those dogs. You're going to PEC the ones that are the classical deep-chested dogs: Rottweilers, Labs, German Shepherds, Standard Poodles, Great Danes.
Yeah, I've seen a Frenchie with a GDV.
Yep. And again, a Frenchie is a good example, because this dog may have had brachycephalic airway syndrome, had some sort of respiratory crisis, aerophasic GDV, because it doesn't make sense that a Frenchie would have GDV, right? The Cocker Spaniel I saw was actually a LARPAR. So we actually ended up cutting the GDV that night and then doing the LARPAR a couple days later, right? So you have to look at that, especially with those less classic cases.
And then since we kind of were on like less classic cases, I have seen, and I don't know if you've seen this as well, animals that have presented and I've been told that have been PEC-ed, and so they automatically rule out a GDV, but yet they still have torsed, either because the placement was off, or for whatever reason maybe the dog was younger and they just stretched out, or had a splenectomy, later on, that it messed it up.
Yeah. So when I talk to clients about the possibility of PEC failure, I usually say it's the dogs that have comorbidities, diabetes, thyroid issues, cancer, etc., Cushing's, disease processes that you can theorize are going to affect healing. And so if the PEC fails, it may not necessarily be the technique of the surgeon, maybe due to that patient's inability to heal well. So there's that aspect. Of course, there's also the surgeon's skill level. That matters too, right? And then there's also the factor of complications of PEC, like colonic entrapment, for example, where the colon moves and it moves cranially, gets displaced, and then kind of hangs over the stomach, kind of like what horses get with their own, nephrosplenic entrapments, right? Where it's not the PEC that's the problem, and it's not a GDV, but it's related to the PEC, and then maybe that requires you to like redo the PEC. So those are all possibilities. I was taught to PEC my dogs with non-absorbable suture, so I usually use Proline, but I know plenty of board-certified surgeons that'll use PDS, which is absorbable. And so it may not be that you use the wrong suture or something like that either, because plenty of surgeons will use absorbable suture as well for PECs. But yeah, you're gonna, if you collect your radiograph and you see the classic double bubble sign like we've been talking about, whether it had a PEC or not in the past, clearly it's got a GDV now, right? And so you have to chase that. You can't just ignore it. And really, what clinician is not going to collect radiographs in a dog with acute abdominal signs anyway? You're going to see the problem. So so don't rule out that possibility. There's still a chance. And I think in the proceedings, or maybe it's in here. Yeah, I said in here a recurrence, 0 to 15%. So it's not zero. There's still a percentage of animals that are gonna have recurrence. Just depends on why it caused that. So don't think that you can't have a recurrence even though the dog was pexied prior.
Perfect. And then the next question is just a question. Do dogs with megaesophagus have the same percentage of chance of GDV as a non-megaesophagus dog?
You know, I almost hate using the word megaesophagus to describe the dilation of the esophagus in this case, because when we think of megaesophagus, you think about an actual neuromuscular disease and not secondary or concurrent esophageal changes from a primary condition. So I'd rather call it something else, like esophageal dilatation or something. But the literature uses megaesophagus, and so until we replace the wording, that's what we have to use. But no, I would not think of it. There's no literature that I found on answering that question, nor have I found it clinically in my experience that having a dilated esophagus means anything post-operatively. I can't even tell you if having a dilated esophagus makes them more prone to having post-op bronchopneumonia either, right? Whereas truly megaesophagus dogs, that's the number one thing you worry about is bronchopneumonia. So I hate that we use that word, but no, I don't think it affects prognosis if they have that on radiographs.
I think she was asking, Shadi, if she has a megaesophagus dog, does that predispose them more to having a GDV?
Oh, not that I've seen clinically, nor that I've read.
Okay.
Yeah.
Okay.
And I imagine if that's true, let's say that's true. I imagine because typically with megaesophagus as a neuromuscular disease, it seems to be isolated, at least gastrointestinally speaking, to the esophagus. It doesn't seem to affect the GI tract diffusely, So I imagine that it just because there's a motility issue with the esophagus doesn't mean they'll have a motility issue with the GI tract, because it's a very specific neurologic condition, not necessarily a GI condition, But no, I haven't seen literature on that or seen it myself.
Cody said that his smallest GDV was an 8-pound, what was that? Maltese, and he actually sent me the radiographs. So I'm just going to share it so you guys can see what it looks like. It's kind of crazy.
Cool. Sure. That's interesting.
It's a little tiny. It won't let me open it more for whatever reason. That's a little dog. And then he said he did trocar this one.
I can't see it, Ashley, but that's okay. If
you can see it. Oh, is it not sharing? Okay.
At least not for me. I only see my slide.
Oh, okay. All right.
I can't see you either anymore, so I don't know what happened.
It's okay. I'm not important. Do we have any other questions while we're here? This was a great lecture. I really appreciate it.
Thank you.
We're going to have Dr. Rafage do some other surgery talks. So if there's some topics that you would like him to touch base on, please let me know in the survey. And if that is it for questions tonight, we're going to let everybody get back to their evening. I appreciate you being here, presenting. If anybody has any questions on Vet Triage or Vet Triage Pro, I do have flyers that I can send to you. You have Dr. Rafage's email address, so please feel free to reach out to them.
Thank you, Ashley.
Don't worry, Cody. I'm not gonna share. Oh, you removed it. Okay, perfect. All right, everybody, have a great night. We'll talk to you later.
Thank you. Bye-bye.